Hip flexion is a common assessment technique that, as a physical therapist, you probably do every single day. The thing that I usually see when it comes to hip flexion is that a lot of us look at it too surface level. What I mean is that as we bring someone through hip flexion, we essentially find where they're limited, call that point tight or normal, and then move on. The thing is, once we dive a little bit deeper and look a little bit more three-dimensionally, we can start to see that hip flexion can tell us so much information. Not just from a restriction standpoint, but it helps us understand our patient's pattern, and ultimately it's going to help us make better exercise decisions. So what I want to do in this video is dive a little bit deeper into what hip flexion really tells us and how we should start to look at it, and it's not something that we've been taught in school. But before we can dive into hip flexion, we need to define one term, and that term is relative motion. So relative motion, as it relates to our hip flexion test, means that the innominate bones can move as the femur is going through hip flexion. So there should be motion at the innominate bones relative to the femur. For example, as we start to flex through the femur, the innominate bones go into external rotation, they go back to internal, and then back to external. More on that to come. The point being is that as someone is moving through hip flexion, if they have full range of motion and they don't compensate. So that means that as you're bringing them through, they get their full 120. They're not internally, externally rotating. They're not deviating in or out, but they have clean motion. This person in front of you is telling you that they have their available relative motion. Now, if you are working with someone, chances are they don't have relative motion because they are probably there to deal with some sort of ache or pain, right? But the point is, if someone can get through full motion with no compensation, that means that we have our available relative motion. And with that, now we can start to look at our hip flexion assessment. So like I previously mentioned, we're not going to look two-dimensionally at our hip flexion assessment, but instead, we're going to look three-dimensionally. And the real thing that we're using it for is to not rule a muscle tight or not, but instead to understand the overall position and influence in the pattern that's going on at the pelvis. Now, how can we do this? Well, a lot of this is from a great research article by Newman. And what he found is that there are three primary phases when it comes to hip flexion. We have 0 to 60, which is an external rotation bias, 60 to 90, which is an internal rotation bias, and then 90 to 120, which is an external rotation bias. So what do these biases and phases mean? Well, first off, if someone has their full range and they don't compensate, we know that they have their full movement capacity and or movement variability. That's great. That type of person probably won't be in pain. But what it means when it comes to the phases and the biases is that now we understand what's expected. So when we don't see normal motion, we know what exactly is wrong with it. Meaning, if someone goes through this phase and they start to externally rotate here, we know that this person doesn't have internal rotation. And so what do we do as physical therapists? We then can go prescribe specific IR biased exercises to improve their movement variability. And so when you don't look two-dimensionally, take a step back and you look three-dimensionally, you get so much more intent behind what you're looking at. So then we don't have to guess, right? And so that's how we're gonna really look at hip flexion and bring it in a very intentional way. Now, my quick disclaimer is, for this video's sake, to keep it short and condensed, I just wanna cover the main principles. If you wanna dive deeper, I will leave the Clinical Coaching Foundations course in the link below. Feel free to click that because we go into a lot more detail, not only when it comes to the lower body, but also the upper body. So now let's go through each phase so we can understand what we should see and then what's going on when we don't see that. So like we said, phase 1, external rotation bias, 0 to 60 degrees of hip flexion. So what this means is if someone can't achieve this, then we know that this person has a hard time achieving an early externally rotated biased position. So what does that mean? Well, if we go through here and they just can't go, they either pinch, you feel a tightness, and or they start deviating externally or internally rotating, then we know that we need to give this person an ER biased exercise. Well, what is an ER biased exercise? It's going to match with our 0 to 60 degrees of hip flexion, but also external rotation is coupled with other motions. And those motions are abduction, flexion, and counter-nutation of the pelvis. So chances are, if someone can't achieve this full range of motion from 0 to 60, they're probably nutated or in an anterior pelvic tilt at the pelvis. So something like a posterior pelvic tilt, getting them to understand how to move the pelvis in a better position should clear up that limitation here. But again, big point is, if you see this, we're not just labeling it tight. We're labeling it that this person is in a position that doesn't allow that. What's going on here, and how do we start intentionally fixing it? Phase number 2 is 60 to 90, and this is everyone's favorite. Why? Because we have an internally rotated biased position. And when you do hip flexion, you kind of know that it's more of an ER biased measure as a whole. But why do we see internal rotation come up here? Well, the quickest and easiest answer is that as we approach 90 degrees of hip flexion, a lot of these posterior muscles actually reorient. What we can think of is our normal piriformis. At the bottom is an external rotator. As we get to 90, it actually becomes an internal rotator. And if you can envision my finger as the fibers of the piriformis, because it's on the anterior aspect of the femur, as that femur comes up, it's actually exposed. So the piriformis is still contracting in the same way, but because of the new position of the femur, it actually internally rotates. And a lot of us know this. If you're in the physical therapy world, we know that the piriformis is an internal rotator as we approach 90 degrees. Think of our classic piriformis stretch. We do it around 90 degrees, but we put the femur in external rotation. Why? Because at this position, internal rotation is its primary action, so we stretch it at external rotation, right? So it makes sense, and I think a lot of us know this, but we don't link it together. So again, what does this mean as a big picture? This means that as we go through this, if someone can't get through this sticking point, or when they start approaching us, they start abducting, external, internal rotating. This means that they don't have internal rotation available at the pelvis. Internal rotation is actually more of this. So chances are these individuals are way too compressed back here. These muscles are not allowing the pelvis to have that relative motion to open up in the back side. So certain exercises need to then be prescribed to improve this patient. Again, we're not just randomly saying this person's tight and stretching them. We have an intentional plan. We need to open up posteriorly back here, which usually is a lot of hinging based exercises, to start to improve this person's movement variability. So our final phase is external rotation. And like we talked about, this is from 90 to 120. Usually what happens here when someone can't achieve full hip flexion is we see the classic butt wink. The butt wink is when we get the flexion through the spine and the whole spine just kind of rounds out. So this person needs specific ER biased exercises from the ranges of 90 to 120. And so once we start to achieve that, we give them their relative motion. Remember, the whole point is to restore relative motion. And when someone can get that full range of motion, like we talked about, they're going through ER, IR, and ER. And so once they get that, they're probably going to be out of pain. But it's really hard to get someone out of pain when we're just guessing and going through the motions when we just look two-dimensionally. So again, taking a step back, looking three-dimensionally is a very intentional way to start to get your patients better outcomes. So I hope you found that helpful, but if you're a little bit confused, here's a quick summary of the main points. Step number 1, we're going to look three-dimensionally at our hip flexion assessment. Instead of really just looking at it from a muscle tight versus not tight, we're looking at it as, where is this person's limitation? Is it ER or IR? From there, we go to step number 2. We're recognizing the 3 different phases: early, mid, and late, which is ER, IR, ER. From there, we have step number 3. If someone can't achieve that certain position, we're not saying that they're tight, we are recognizing that they don't have relative motion. And so, depending on the phase of their limitation, we either need to give them exercises that has an ER biased exercise, an IR biased exercise, or an ER, right? And you just correlate that with our hip flexion. Once we start to do that, we can start to get better results for our patients, because we're not just stretching what we consider a tight muscle, but we're actually restoring movement, which is going to increase their movement variability.